Hello, we're here today with Dr. Margaret Bauman to talk about medical comorbidities in persons with autism and their clinical and research ramifications. I'm Marvin Natowicz. I'm a medical geneticist and pathologist at the Cleveland Clinic, and Dr. Margaret Bauman is a well-known specialist in the evaluation and care of individuals with developmental disabilities, who for most of her career has been associated with the Harvard Medical School and Massachusetts General Hospital, and more recently is affiliated with the Boston University School of Medicine. In addition to her extensive clinical expertise in autism, she's an accomplished researcher as well, and we're fortunate to have her here today to talk about the issue of medical comorbidities. The specific learning objectives for today's webinar include a discussion of the importance of medical comorbidities for persons with autism. Why are we even talking about this topic? Second, we hope to review the common medical comorbidities and discuss their diagnostic recognition, which in some instances can be very challenging and is important if they're missed. And third, we hope to discuss important clinical and clinical research needs in the field. So to begin with, Dr. Bauman, could you review with us why we're even talking about this particular issue? What is the importance of talking about medical comorbidities in persons, be they young children or even adults, with autism?
Well, I think that the real importance is that if people don't feel well, they're not going to do well. And that could be you and me. We all know that if we have a bad day or we have a bad cold or we have a stomach ache or whatever it is that we have, this is just not going to be a good day at the office or where with our families or whatever it is. So I think that being able to diagnose some of these comorbid medical concerns really have an impact on how these kids are going to be able to do on a day-to-day basis. For example, if we have a child with an earache, is that a child who's going to have negative behaviors or somehow become aggressive or self-injurious because he can't tell us that his ear hurts, and things aren't going to go well at the school or the school program. So I think primarily it's really, if kids feel better, they're going to do better, and the developmental outcomes will be better. I think secondly, one of the concerns we have now going forward with this is that if we have medical comorbidities, which I think to a large extent have been generally ignored until relatively recently, would this help us begin to define subgroups of kids on the autism spectrum? Right now, people are seeing, or have been for a while, been seeing children, adolescents, and adults. Autism is a sort of a single entity. Not to say that we didn't recognize there were differences among these people, but that we've not really thought about them as maybe there are multiple ways that you get this. Maybe there are multiple medical concerns that we need to know about that will inform us as to what the underlying neurobiologies are here. So maybe this can really help us in terms of getting a better grasp on these subgroups and then talking about causes and potentially more reasonable treatments, the more effective treatments down the line.
Mm-hmm. And comorbidities, medical comorbidities can potentially involve any organ system. Mm-hmm. Can you speak to some of the comorbid disorders of the gastrointestinal system?
Okay, well, recognizing that I'm not a gastroenterologist, I've had the advantage of working in a multidisciplinary clinic, and that's really taught me a lot. I'm a neurologist by training, and certainly in my training we were not talking about gastroenterology or any other discipline. We were talking about neurology. But because I've got the advantage of working in a multidisciplinary clinic, and because I've got gastroenterologist, for example, who can consult with me and who just live down the hall from me, I can just go and ask a question, which is worth its weight in gold, frankly. But in any case, so what kinds of GI issues would we might see? There can be almost anything you could think of, quite honestly. And I think one of the more common ones is gastroesophageal reflux disease, or what's called GERD, G-E-R-D. But I think that's fairly common in this disorder. But we see gastritis, esophagitis, colitis, ulcers. We see Crohn's disease. We see celiac disease. It's almost any inflammatory bowel disease, eosinophilic esophagitis. It can be almost anything you could think. I wouldn't tell you that it's anything specific. I think one of the big challenges in this whole field, however, is that these children don't typically present with the kinds of symptoms that your average gastroenterologist would recognize, or frankly, your average primary care physician would recognize. They don't. First of all, we've got children who are largely nonverbal. At least 50% of the population is estimated to be either nonverbal or hypoverbal, and really can't tell us about pain and discomfort. They also have sensory processing issues, so they can't necessarily localize where the pain and discomfort is. So given that, how are they going to convey to somebody that things aren't going well? And one of the things that they often do is to show up with disruptive behaviors. And this could be aggressions, it can be self-injurious behaviors, it can be tapping on your chest, it can be pushing your abdomen up against something firm, it could be a whole host of odd behaviors, funny arm movements, facial grimacing, we've sort of devised a kind of a list of these sort of target behaviors, but there are probably others we haven't even thought about yet. But the bottom line is that if children show up with either oddball behaviors that we can't explain in some other logical way, or their behavior patterns have changed dramatically, in my humble opinion, that deserves a one-way ticket to the gastroenterologist, because I think GI issues are common enough in this disorder that they need to be at least investigated and ruled out before we move on to assuming that this is just part of something else, that they're anxious or whatever else is going on. So I think that the GI issues are a high priority here. The data in terms of prevalence of these things, by the way, in autism is very variable, and it depends upon who wrote the paper and what study was done. And I've seen prevalence rates varying from 20% to 80%, but I think it really depends upon the cohort or the study group that's being studied and what the questions are being asked. And I think, quite honestly, we really don't know what the prevalence rate really is at this point. We really need the research to tell us that.
But it sounds like, from what you're saying, that another major importance of having this webinar talking about medical comorbidities and autism isn't just to secure better health for the person and from a research point of view to enable accurate subsetting, but also to inform us about the possibility that some of these medical comorbidities, if I'm hearing you correctly, can, when present, provoke aberrant behaviors that could be mistaken for quote-unquote autistic behaviors.
Absolutely.
And that would be another quite significant reason for talking about this topic, and potentially not just pertinent to the GI comorbidities, but pretty much comorbidities in many of the organ systems.
Yes, I think that's absolutely true. I think that's been one of the problems, and I think one of the questions that's often asked is, well, if they have all these medical problems, why have these been missed all these years? And I think it's been missed because people have just assumed that these behaviors are just part of somebody's autism, and they really haven't gone beyond that. And I think back on the years that we were doing a lot of our postmortem work, and we've obviously learned the cause of death and all the details when we get one of these cases. And we have at least one case where the child had a ruptured appendix and nobody knew it until he was moribund, and another case where somebody had a ruptured peptic ulcer and clearly wasn't picked up either. So I think they also do have implications for, is somebody going to survive here? So I think that it's an important topic.
Mm-hmm. And can you comment on other types of medical conditions that occur in persons with autism that are of importance to primary care physicians as well as specialists taking care of persons with autism? For example, can you comment on dental conditions that one might see in persons with autism, why they might be important, and how they might be missed?
Yeah. Well, I think it's it's almost anything that anybody else could have. I mean, just because somebody's autistic doesn't mean they can't have anything you could think of. So yes, dental problems, of course. A lot of our kids, first of all, in the age where they were doing a lot of positive reinforcers with M&Ms or chips or something, and it wasn't really helping you in terms of your cavities and the frequency that you're going to be having to go to the dentist. Secondly, trying to get one of these kids into the dental chair so you can actually look at them and clean their teeth and brush their teeth has been a challenge. A lot of the parents, some of their early programs, as you know, are just toothbrushing kinds of programs. I mean, they have a lot of sensitivity, so they don't want somebody futzing around with their mouth very much. So that's a challenge. Certainly dental pain can be a significant issue when the kids get older. We've got wisdom teeth coming in, and I've got a bunch of teenagers now who need to have their wisdom teeth taken out because it's really pretty uncomfortable for them. So, dental problems are an ongoing issue, but there are many other problems. So, earaches. I mean, that sounds like a fairly simple problem that somebody ought to be able to say something about, but these children cannot tell you that the ear hurts. And I had a little anecdote about a young man who was 12, who was a very large young man of age 12, who lived in New Hampshire, and his mother called me on a Sunday night about 9 p.m. to tell me that she was locked in her bathroom. Her husband was out of town. I learned that husbands generally are out of town when these crises occur, unfortunately. But anyway, she was locked in her bathroom because he'd become aggressive towards her, and she didn't know what to do. And I said, well, you really need to get to an emergency room. This is really not going very well. And maybe you can get somebody from the school to come help you. And I mean, the woman's in New Hampshire. And she said, well, I want to come down to the Mass General Hospital. Well, I mean, it's a good hour's drive. And I said, well, you would need to go closer. No, I want to come to the MGH. Well, anyway, so I called the pediatric psychiatric emergency room. Okay, now, nothing against psychiatrists, except the psychiatrists don't generally physically examine somebody. They generally talk about anxiety and OCD and so forth, but they don't generally look in your ears or whatever. But this particular night, for whatever reason, they get to the emergency room and they did do an examination, and it turned out the young man had bilateral otitis media, had bilateral ear infections. They gave him penicillin, shot him up with some penicillin in the emergency room. He fell asleep there. Next morning, he gets up and walks out like nothing ever happened before. And I think, this was a guy who was essentially nonverbal or hypoverbal, who couldn't even point to his ear and tell his mother that his ear hurt, and he was reacting by becoming aggressive towards her or self-injurious and what have you. So I think they don't give you the clues. They just don't give you the clues. We have kids with urinary tract infections. So, for example, we can have kids who have been continent who suddenly become incontinent for some bizarre reason, and somebody starts talking about are they anxious? What's going on at home? What's going on at school? Is this behavioral? I mean, heaven forbid we should look at whether he's got a urinary tract problem. We've got kids who have genuine allergies. We have kids with big tonsils and adenoids, which just aren't sleeping well, or frankly, swallowing very well. So it's almost any kind of disorder that typical kids would have. We just need to ask the questions, and generally the markers are behavioral. They are not children who are going to literally point to or tell you, my head hurts, my tummy hurts, my anything hurts. We have kids who hit their heads, and people assume that those are headaches, but they may not be headaches. They may be some other problem. They just simply can't locate the problem. And I guess one other anecdote is I gave a presentation at a conference some years ago where I was talking about some of the GI issues. And a young woman with Asperger's syndrome, very bright lady, comes up to me afterwards and she said, when I get sick, it takes me 3 days to figure out what's wrong, where my problem is. And I'm thinking to myself, here's this very intelligent young woman who it takes her 3 days to figure out what's wrong here. I mean, what do we do with the kids who are maybe less able to do that? How are they going to convey what it is that they know or how they're feeling? And I think, we as the physicians are really going to have to be the ones that do the looking and the thinking out of the box to try to figure this out.
Do you have any special suggestions or recommendations for emergency room personnel when they see someone along the autism spectrum who's brought in?
That's a big question. I think that they're now putting together teams in a lot of hospitals who have hopefully experience working with the autism population. I mean, an emergency room experience is difficult for anyone, much less a child or a children, adolescent, or adult with autism. So I don't know that I can tell people what to do exactly, except that I hope that we get information to emergency room so that they at least have one or two people who know what to do. The whole experience going to an emergency room it's overwhelming, it's noisy, it's people are bustling around, there's no routine, somebody comes in, somebody goes out, they're going to ask you a lot of questions, people are going to be touching you. This is an autistic person's nightmare from every angle you can possibly think of. So you hope that someone is going to be there who is going to be able to navigate the situation on behalf of the patient. I think what parents can do in advance, frankly, is to write up a list of things. My child doesn't like people to touch them. My child responds best to whatever. My child needs a quiet environment. My child doesn't respond to fluorescent lights because they flicker. Whatever, so that somebody has some kind of a guideline as to what they can or cannot do. But it's a particularly challenging situation in any kind of an emergency room for these kids. Also, frankly, inpatient hospitalizations as well. It's the same problem. I think our general medical programs, including hospitals, are not well prepared for these children. The pediatric groups are better prepared. The adult groups are not prepared at all. They really are totally unprepared. We had a young man who just I sent him over, 33 years old, sent him over to the hospital to get an EEG. And it took us 3 months. Who's going to be there? Which door is he going to go into? How's it going to be handled? Blah, 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 blah. Okay, the guy gets to the gets to the EEG lab and has a total meltdown in the EEG lab. The first response of the people there is call pediatrics. You can't call pediatrics. The guy's 33 years old. You, the adult service, need to have this kind of information so that you know when an adult comes through how to handle this. So we need to do a lot more education, and particularly with the increasing prevalence rates here. This is not some oddball, unusual disorder. We're going to be seeing these folks pretty commonly.
You mentioned the challenges in the emergency room setting for evaluating persons with autism. In a outpatient setting, what is the ideal space to evaluate, say, a toddler or an older child or an adult? What are some of the issues that you think would make it a better encounter for that person, and some of the issues or design features that would make it less than optimal?
Well, this is a very complex disorder, and it's obviously heterogeneous, so it's not one size fits all. So let's just preface it with that. But I think in terms of the way we've set up our programs is that we have a waiting area that's for the children, and we have a waiting area that's for the older kids and the adults. So we've tried to separate them out a little bit, because sometimes the younger children can be sort of intimidated by the bigger kids, and sometimes the bigger kids make more noises. It can be pretty scary depending upon what kind of a day it is. Usually it's, we try to avoid the fluorescent lights. We try to keep the noise levels as low as we possibly can, which is challenging. We try to have, frankly, lots of toys around that the kids like to play with. We sometimes encourage families to bring their own toys, and so parents will come in with bags of things that they know their child likes to have. Sometimes they'll come with snacks, which is fine. They'll always ask me, is it all right if he has a snack? Is it all right? Absolutely. I don't care whether he has a snack or not. Oftentimes they're coming now with their little iPads and stuff, and these kids are big techies, so you give them their little iPad and they're just happy as clams while you do whatever it is that you're doing. I think also just being conscious about how to approach these kids. When I'm examining a child, for example, I almost always show them what I'm going to do first on myself or on their mother or something like that, because I think the large majority of them are visual learners, not auditory learners, and they don't like the unexpected. So if you're going to touch their back, sometimes I'll let them listen to their own heart first, or put this on their leg, or if I want to do the stethoscope. I mean, it's not always perfect for sure, but just showing, doing, prefacing really helps a lot. A lot of the parents will use social stories before they even come to the doctor's office or the dentist's office. In terms of you were talking a little bit earlier about dental care. Sometimes just getting the child into the dentist's office in the first place is a challenge. So sometimes some dentists of our way now will have sessions where they'll just let the child come in and they'll get used to being in the waiting room. And then the next time they come, they'll just come and sit in the dental chair. And the next time they come in, they'll do something else. And sometimes it can take weekly visits over a 6-month period just to get the child into the dental chair. So I think, but I think once those things happen, it's a fairly successful situation. But I think making it as calm as you possibly can. We also have a room, by the way, we call our quiet room. And sometimes if the waiting room is too noisy, we'll have the kids and the family sit in the quiet room, and it's sort of away from the general mix.
Your own clinic that you've run in Massachusetts and another clinic that you've directed in California have been multidisciplinary center-based clinics. Mm-hmm. Can you comment on what you perceive as the relevance or importance of a multidisciplinary approach, both from the perspective of the individual and his or her family, as well as from the perspective of a clinician trying to provide care?
I think the huge advantage is that these kids are complicated, and having the multidisciplinary group there, that's not only just that we're not just sort of sharing space, but we're also communicating with each other. So that if I have a child that I am concerned about a motor problem, and gee, should I really send this child to the physical therapist or something, I can walk down the hall, find the physical therapist, come in, could you just take a quick look at this? Is this a child who really needs further evaluation, or what do you think is really going on? Or the gastroenterologist, I could just walk down the hall and do the same. Huge advantage, because ordinarily what one would have to do is, in this case, call the gastroenterologist on the phone, or actually send him or her an email. Of course, it's going to be a day or two before they finally get back to you, and by that time, quite honestly, I forget who I was calling about, what the question was. So it doesn't really help me as much to do that, as opposed to just have the availability of these people available to me. The other thing that's helpful, I think, is that we all learn from each other. I don't know a lot about speech and language. I don't know a lot about OTs or what ear, nose, and throat people do or whatever, but I've learned an enormous amount from those people and what they've taught me, and I think it's helpful to families to be able to have this sort of integrated approach. I think the third thing is that it really keeps people from having to go to various places to get their services. So, for example, sometimes, this person has to go over here to get their speech therapy, and then they go over here to get their occupational therapy, and then they go over here to get their physical therapy, but nobody's talking to each other. They're all doing these, they're like in silos. And so to be able to integrate this and make some sense out of it really helps everybody in terms of how they carry over some of the disciplines. So the OT and the speech pathologist, for example, may share information so that each time that each one of them sees this child, they're carrying over, the OT is carrying over some of the speech components, and the speech pathologist is carrying over some of the OT components and so forth. So it really kind of helps maximize not only the understanding of the child, but also the therapies.
Now, abundant data now indicate that the medical comorbidities seen in persons with autism are significantly overrepresented in the autism populations relative to both the general population and even population of individuals in tertiary health centers. And in general, the burden of all these comorbidities goes well beyond that which is routinely managed in developmental medicine centers or developmental medicine clinics. From your perspective, what are the ramifications of this epidemiological work?
Ramifications for the patient, or financially, or what are you talking
for planning health care for persons with autism?
Well, I think the ramifications for planning health care is that we need a lot of people involved here, because if this is true, then yes, we need to be very good at looking lots of different subspecialties as to what the issues are, and have people trained to know how to look for them and to treat them. So I think that's probably the huge ramification. I think, is this true? I gather that it's true. I don't know in my personal practice whether I feel like of course, I have a very slanted view of this, so it's a little hard to tell, but I don't know whether I really feel I'm seeing more GI issues in these kids versus somebody else. But that said, I think, it does have a financial implication in terms of insurance companies. I think it also, though, must be telling us something about the underlying neurobiology here that we really haven't figured out yet. And I think some of these disorders are giving us clues, and we deserve to, or need to, look at those from a research perspective.
In addition to education and greater involvement with non-developmental and non-neurological specialists that you've mentioned, are there other pressing healthcare needs that are paramount, in your opinion, in terms of the medical comorbidities and autism?
Okay, well, sleep disorders are huge, and sleep disorders can be neurological, but they can also be based on other things such as gastrointestinal symptoms or ear, nose, and throat symptoms or sensory processing symptoms or whatever. So that it's not just he's having trouble sleeping. There are issues related to hormonal factors. So, for example, we see a number of teenage girls who have a lot of behaviors as they're going through their menstrual periods. The mother typically comes in and says something like, I can always tell when she's at mid-cycle because her behavior goes off the wall or whatever. And we have a neuroendocrinologist in the Boston area who we've engaged. I don't think the poor man really ever thought he'd see anybody with autism, but we've engaged him nonetheless. Well, it's found that a number of these girls have imbalances between their estrogen and their progesterone, and when that's rebalanced, these behaviors dissipate, they go away. So it's one area that
fascinating.
It is fascinating, and it needs to be, I think, frankly, looked at in a little more detail. We've got some kids who develop urinary incontinence. These typically have been boys, they've typically been preteens, but that doesn't mean that means just what our population has been so far. And, someone's always looking for some kind of behavioral issue about this. Well, sent them to the urologist. Turns out that most of these kids have had spastic bladders. Now, why they have spastic bladders, I have absolutely no idea, but that's a treatable condition. And when it's treated, everybody's happy, the child becomes continent, and off they go again. And then there's a whole host of metabolic disorders that we really need to start looking at, and some of which you and I have looked at together, which are the mitochondrial disorders in particular, and have come up with sort of our clinical red flags for what those are. And some of those kids have done very well on treatment as well, have improved dramatically. But there are a whole host of other medical issues. There are issues of obesity, for example, and I think a lot of that comes from some of the diets that these children either self-select or are given, or some of the reinforcers that they're given as part of their programs. They're also not particularly athletic, so some of them tend to be, particularly now that we've got iPads, they're perfectly happy to sit and do their little technical thingy without moving very much. So, getting these kids out to do something, even just walking is an important thing. Swimming, any kind of athletic sport would be good. Osteoporosis has become a concern because of, the self-selected diet. So we need to be cautious about that. We've been very, very concerned about PANDAS, which is PANDAS, which is believed to be associated with strep infections. And we've seen some very odd behaviors that have come out of that. That's a treatable disorder. Lyme disease, at least in our neck of the woods, is a hot topic. So we have to test the kids for that. Injuries, fractures, anything that any other child could have needs to be considered here. But with the knowledge that these kids are not going to present with the typical symptoms, they are simply not going to do that.
And don't have the communication skills oftentimes
absolutely.
To let you know what's hurting
Even
them.
with their devices. I mean, we have one where we say, how much does this hurt kind of thing. I mean, sometimes it works, sometimes it doesn't. And just because the child isn't even communicating on his or her device about where the problem is doesn't mean it's not there.
So that would seem to be an extremely important message
Absolutely.
here. Okay. Well, thank you very much for sharing your insights about the medical comorbidities in this group of persons.
Thank you.
Dr. Bauman, would you be able to provide us with your perspective on some of the most pressing clinical and policy needs in terms of general medical issues for children and adults with autism?
For many years, we've neglected the medical care of children, adolescents, and adults on the autism spectrum, in large part, I believe, because it's been difficult for physicians to get beyond some of the behaviors that many of these individuals present with. Thus, we have very little idea about medical concerns. Unlike the disorders that are evident in typically developing individuals such as asthma, ear infections, gastrointestinal problems, headaches, and so forth, we have no standards of care either in terms of diagnosis or treatment for these individuals, and I consider that a very high priority going forward.